My name is Daniel Otunge. I'm the director of Africa Science Media Center, which is basically bringing together experts and journalists so that they can be able to talk and understand what is going on in the world of science and be able to address issues, the emerging issues that are headline issues in the media across Africa. And COVID-19 is one of them. It's still with us and that will be with us forever. As you all know, is already rising again all over the world. Some parts of the world, like China and others, are still under lockdown. Here in Kenya, they have just reintroduced mandatory mask wearing in public places, which means the Ministry of Health is having serious concerns about COVID. And I believe this is all over Africa. And one of the key issues that usually make such diseases become a major problem as they are more than they are supposed to be is because of things like stigma and discrimination. We saw this with HIV/AIDS, which Dr. Amu and Gideon, you are all experts in those areas. You can be able to link the two. And we are also seeing this with COVID, not only in Kenya, but also in Ghana. You have proven that actually by conducting research to show that there is stigma against some people who are survivors of COVID-19. Therefore, I would like to invite Dr. Amu or Dr. Gideon, whoever is going to go first, so that you maybe emphasize on this and then go ahead and make your presentation for about 30 to 40 minutes at most. Then you will leave time for the journalists. And I think that will be it. Others can be followed afterwards, after you have already made your presentation and interacted with the journalists. So thank you very much, Dr. Amu. The floor is yours.
All right. Thank you very much, Daniel, for putting this together and inviting us to present our findings, which are very informative to the solutions that we all want to have when it comes to the COVID-19. And as you mentioned in your introduction, it's a major challenge, wreaking havoc on health systems across the world. And so research that lets us understand how it works and then how we can address it head on is essential. And so we are happy that we have this opportunity to share our research with the world. So thank you once again for putting this together. My colleague, Gideon, will start, and then at a point I will take over and then end the presentation. Thank you.
All right. Thank you very much, Daniel and Hubert. Good morning to colleagues in Ghana, and then good afternoon to colleagues in Kenya and elsewhere. I know it's about 1 o'clock in Kenya. All right, so as Dr. Amu rightly said, this investigation involved a number of co-investigators, about 11 of us. And Dr. Hubert Amu is the corresponding author for the manuscript that we have been able to produce out of this study. And now I'm a co-investigator with the principal investigator, Dr. Eric Osei in Korea, who is unable to join us now. So I'm just going to do the presentation on behalf of the 9 other co-investigators who are involved in this study. And I'm going to give the outline of the presentation will involve the background, where I'm going to share just a brief background of the study, and then take you through the problem statement and why the justification for the study, and then the objectives. And then I'll also take you through the methods, and then Dr. Amu will come in to share the key findings of the study with us and conclude, and also share policy recommendations with us as well.
Sorry,
so
Gideon, just 1 minute. Just to be sure, was the embargo on the paper lifted so that we can be able to share it? It was supposed to be lifted yesterday.
Yes. It was published yesterday.
Okay, thank you very much.
Yeah.
Thank you.
So we are very happy that, it's been prompt. It was published yesterday, and just today, a day after, less than 24 hours, here we are sharing the findings. And so we are excited that you could put this together. So by way of background, the coronavirus disease, or COVID-19, started as an outbreak in Wuhan, China in December of 2019. And within 3 months, the world had recorded more than 100,000 cases in about 114 countries. And this resulted in the death of more than 4,000 people. And so on March 11th, 2020, the World Health Organization declared it as a global pandemic. And since then, it has caused major devastation to health systems globally and resulted in more than 500 million confirmed cases and resulted in the death of more than 6 million people as at 21st June of 2022. And this according to the WHO. Now, Ghana reported its first case, 2 cases of COVID-19 on March 12, 2020. And since then, the country has reported as many as 164,000 confirmed cases and 1,400 deaths to the WHO. And we know that historically, infectious diseases have always generated fears among population. HIV has been with us for 4 decades now. And we know the kinds of fears that the disease generated in the population. And just like HIV, which had a lot of unknowns when it was first discovered, COVID-19 also experienced similar things. And whenever there's an unhealthy handling of these fears, it results in stigma and discrimination of infected patients. Now, we refer to stigma as any negative regard or inferior status or relative powerlessness that society collectively accords to people who possess certain characteristics or belong to a certain group or category. And stigma is often endorsed through discrimination, where discrimination is the rejection of people of different category based on maybe their age, their health status. And so all of these things are major public health threats. And we saw many of them happening during the COVID-19 pandemic, at the peak of it. Now, in Ghana, there were several media reports of stigma and discrimination towards COVID-19 patients, and not just them, but their families as well, since the first case was reported in the country. For example, one survivor, where we define a COVID-19 survivor as someone who has tested positive for coronavirus or who has antibodies that are indicative of having the coronavirus infection. And a survivor on a radio station in Ghana bemoaned how his whole family were stigmatized and that they were not even able to enter into supermarkets to buy certain goods. And even their children were pointed at in the neighborhood by their friends and their colleagues. And some were actually, children were refused entry into schools because their parents tested positive for COVID-19. And so given that much media report, it compelled even the president of the country to call on all Ghanaians to stop stigmatizing and discriminating against COVID-19 survivors. I mean, with a case fatality rate of less than 1%, the president was right to say that COVID-19 is not a death sentence. And so he called on all to stop stigmatizing. And if I can quote the Chief Psychiatric Officer of Ghana, Dr. Akwesi Asare, he said that whenever there's stigma on affected people, it puts a lot of stress on them, and it even worsens their plight, and all underlying conditions and others will then come to the fore. So given that much scientific research had not been done to verify these claims, as public health researchers with the right tools and expertise, we sought to examine the prevalence and the predictors of COVID-19 stigma and victimization among survivors of the disease in Ghana. The next slide. I'm not able to move. Okay. And we define a COVID-19 survivor as a person who has tested positive for coronavirus or who were later confirmed to have the virus by testing positive for the antibodies. And how did we carry out this research? It was a population-based descriptive cross-sectional study involving Ghanaians 18 years and above. And the sampling procedure was what we term as a multi-stage sampling. Ghana is quite peculiar. It is located north of the equator and it's bordered by La Côte d'Ivoire and Togo, and the Burkina Faso to the north, and the Gulf of Guinea to the south. And so you can see clearly that there are 3 ecological zones that are present in Ghana. And so for the purpose of this study, to be able to estimate and compare different ecological zones, we stratify the country into 3 different zones. That's the savanna zone, the middle zone, and the coastal zone. And there are 16 administrative regions in Ghana. For the selection of the regions, for each of the zones that were stratified, we randomly selected 3 regions from the zones. And then within the zones, we randomly selected 2 districts. And to be able to have both rural and urban areas, we grouped the districts into rural and then urban districts so that we could sample from both cases. In terms of the clusters, we randomly selected clusters within this district, and data collectors were able to then go into households to collect the data. The data collection period was from October to November of the year 2020. And we used a questionnaire which had socio-demographic characteristics such as the age, sex, marital status, occupation, education, religion, among many others. And then also we collected information on social stigma and discriminatory attitudes to measure the fear of causal transmission and refusal of contacts. And then also we collected information on the knowledge of disease transmission and signs and symptoms, as well as the general attitude towards COVID-19 patients or survivors. And the questionnaire was administered in the form of what we call the computer-assisted personal interviews, where it was the electronic copies of the questionnaires were loaded on smartphones for the data collectors. And then they used these questionnaires to move from house to house randomly to select participants for the study. Before the study was done, we sought ethical clearance from the Research Ethics Committee of the University of Health and Allied Sciences before we did that. In terms of the measurement of stigma and discrimination, to assess the level of stigma and discrimination of respondents, we used 5 answerable questions, which were indexed to assess the level of stigma and discrimination. And the respondents were assigned to a score of 1 for a positive stigma attitude, and then 0 for a negative stigma attitude. And the cumulative scores that were obtained were then converted to percentages. And individuals or respondents who scored above the average stigma score were considered to have no stigma. And those who had lower than average percentage scores were then classified to have stigma or discriminatory tendencies. Our data, after collecting the data, we analyzed using status software where we're able to generate frequencies, percentages, and the chi-square test was used to measure associations between the variables that we collected. And the predictors of stigma and discriminatory attitudes were then measured using logistic regressions. So at this point, I'll hand over to my colleague, the corresponding author, Dr. Amu, to share with us the key findings from this study. Thank you very much.
All right, thank you, Gideon, for the wonderful presentation. I'll take over and continue from where Gideon left off to start off with the key findings. So what were the findings we made after the rigorous nationwide study that we did? I'll start with our background information. This chart only talks about the key findings. And so even though there were other variables and other attributes of those variables in our study, we are highlighting only the key ones. So for instance, in terms of age, we realize that the comparative majority of the participants, the adults we included in our study, were in their 20s, and that constituted 43%. Then in terms of sex, males were a little more than the females with a percentage of 54.9%. And I'm talking about a total number of 3,529 that were actually recruited for this study. And in terms of education, the comparative majority had completed, we call it JHS or SHS at the time of the study, and that made up 44.1%. Now, marital status, those who were single, so we regrouped the marital statuses to have those who were single, those who were married, and those who were cohabiting. And then Those who were single had almost half of the study population of 49.6%. Now, religion, Ghana is predominantly Christian, and so it was not a surprise that about 66.6% of our participants were Christians. And then, of course, in terms of average income, we found that 44% were earning less than 355 Ghana cedis. Okay, thank you. Let's move on to the next slide. Gideon, the next slide, please. All right, so our main outcome variable, as Gideon mentioned in his presentation, was stigma and discrimination. And he indicated that we had a number of questions that we put together and then found indices out of to give us the overall discrimination scale. And so these are the 5 questions for want of clarity. And that's the main reason I projected this. Let's go to the next slide. So out of those 5 questions, we were able to estimate the overall level of stigmatization, and then production is key. When people have knowledge, they are able to take actions on that. So we saw knowledge as a very important variable that we could include in our analysis. And so this was the knowledge scale I presented so that those who have not already seen the paper would have that idea. So there were a number of questions that were posed. So for instance, coronavirus can be transmitted through the air, and then the person has to decide whether it's yes, it's no, or they don't know. And then it goes all the way to the last one. The coronavirus pandemic is a curse from God. So depending on the answer you pick, we are going to create an index variable called poor knowledge or good knowledge out of these lots of variables. Next, please. And then apart from knowledge, attitude is also key in people exhibiting stigma and discriminatory tendencies. And so we added it to our variable, our study, based on also other studies that had in the past seen very important relationships between attitude, knowledge, perception, and outcome variables. And that was one of the reasons we added attitude in our study. And these are the variables that constituted the attitude scale. What I'm saying is that it means there are 1, 2, 3, 4, a number of things here. We will ask you all of these questions. Then based on your responses to each of them, we create an aggregate, more like a collection of your responses. And then we can then say, oh, because you have said yes to 5 out of the 9 questions, or because you have said no to 6 out of the 9 questions, it means that you are likely to have a negative or poor attitude towards COVID-19, or you're likely to have a positive attitude. So that is what this table means. So out of this, we came up with an overall attitude variable. That's to be able to measure attitude towards COVID-19, which is a factor that can predict somebody's ability or tendency to discriminate or stigmatize against someone. Please, next page. Yes, so this is the knowledge overall outcome variable. And you realize that about 34% of the participants had poor knowledge on COVID-19. And once knowledge is poor, then it's likely the person is going to act out of ignorance to probably stigmatize the neighbor. Next, please. And then this is the outcome variable for attitude. And you also realize that it's also quite high. 43% of our 3,529 participants had poor attitude towards COVID-19. Thank you. Next slide, please. Okay, so as Gideon mentioned, we did inferential analysis, which is a statistical tool called regression, tries to see if there are any relationships statistically between our outcome variable, which is stigma and discrimination, whether somebody has done that or not, and then our explanatory variable, which are variables or things that are likely to influence the outcome, which is stigma and discrimination. And so regression is an important analytical tool we use to predict that association. And then it also tells us the direction that that relationship is likely to take. And I've highlighted some of them in green. Those are the ones that are of interest to us. As I mentioned earlier, there were other variables, other things. Variable is that thing you are measuring, for want of a better word. And income, for instance, was one of them. Sex, age were all in it, but we did not find a very good relationship or association between those ones and then somebody having the likelihood of stigmatizing and discriminating against a survivor. And so they are not in this table. So this table captures only those characteristics or variables, as I keep calling it, that are likely to have implications for somebody stigmatizing and discriminating another. And as I mentioned, income was very highly correlated. There was some significant relationship, which we measured at 0.05. It's a statistical thing we do, so don't worry yourself so much about it. That is what we are calling p-value. We look at my right-hand side, p-value, for us to say that there is a good relationship or statistically significant association between, for instance, monthly income, and then depending on your monthly income, you being able to stigmatize or discriminate against somebody. It means that that p-value should be less than 0.05. It's statistical, so don't mind me. Now, you realize in the column AOR. Now the AOR is like, first we do the COR. The COR is crude odds ratio, which looks at only the relationship between monthly income and then stigma and discrimination tendency. Now, we all know that your income can play a role, and then let's say your level of knowledge can also play a role. But for the COR, we are not interested in whether your knowledge will affect your income, to affect you being able to discriminate or stigmatize against somebody. We are not interested when we are doing the COR. So COR is just a bivariable relationship between the two. Now, knowing that there are what we call covariates, other things that can affect another person's relationship. In this case, if you are looking at monthly income and stigma, monthly income can depend on, let's say, knowledge. So you have the money, all right, but then your knowledge is not good. And so that we are saying can affect the relationship. So we then do the AOR, adjusted odds ratio, so that we are taking cognizance of the fact that income does not operate alone to influence stigma. Definitely, there will be some amount of maybe risk perception, knowledge on COVID-19, and then attitude, which can all affect an individual's ability to stigmatize or discriminate against another. So that is the AOR. And so in statistical analysis, we focus more on the adjusted odds ratio because it tells us that you are not an island. Other things will definitely affect you. That is what it means, basically. So focusing on the AOR with that explanation now, what the green means for the column against monthly income is that as your income increases, your likelihood of stigmatizing and discriminating against a survivor of COVID-19 gets higher. Now, you see something there, ref. Statistically, we put it at 1. So if, let's say, the reference category is income of less than 355, then it's at 1. Anything that has a value, which I have, the green one I have indicated, above 1 means the tendency or the likelihood is higher than that of the reference category. Once it is less than 1, then it means the reference category has a higher likelihood to do the outcome variable, which in this case is the stigma and discrimination. I'm sure I hope it's clear. Now, with that explanation again, we are saying that those who have an income of between 355 to 500 Ghana cedis have about 2% chance higher than those who have an income less than 355 cedis to stigmatize and discriminate against those who are survivors of the disease. That's what we are saying. And so you realize that the numbers keep increasing. So from 1.02 to 1.35 to 1.37, and then it remained there. That means the probability of stigmatizing and discriminating against a COVID-19 survivor increased with monthly income. Now, COVID-19 risk perception, we asked that as a variable. Now we asked, do you see yourself as being at risk of getting COVID-19? And then some people said, no, that thing, I won't get it. I can't get it. There were responses like that. So if you choose that option, then you are telling us not at risk. And then if you choose at risk, then it means you recognize that, oh, I can get COVID-19. Now, the analysis is showing us that, so you realize that in this case, we have 0.65. And with the explanation I gave earlier, I said that the reference category is pegged at 1. So anything less than 1 means that attribute is less likely to do the outcome than the reference category. So the implication here, therefore, is that those who said they are not at any risk, they just decided that they are not at risk of getting COVID-19, were less likely to rather do what? Stigmatize and discriminate against people with the disease who are survivors, as Gideon described earlier. Now, the two very important variables that we were much interested in, which showed very important findings, were knowledge and attitude, as we even described earlier in our descriptive statistics, where you realize that participants who had poor knowledge were about 91% more likely to stigmatize and discriminate against those who were survivors of the disease. So it tells you knowledge, poor knowledge is a big challenge. If you're not aware, that is when you're going to act on your ignorance to end up stigmatizing and discriminating against somebody. And then, of course, you realize that even that for attitude was even worse in the fact that while the one for knowledge is 1.91, this one is 5.83. Now, because the thing is pegged at 1, the reference category is pegged at 1, you just deduct 1 from the 5, which tells you that those who had poor attitude were 4.83 times more likely to stigmatize and discriminate against survivors of COVID-19. And this is very serious and worrying. Next slide, please. So based on these findings, what are we saying? We are saying that stigma and discriminatory tendencies are considerably high. You saw the 40-something% and all of that, considerably high. Now, we are saying that stigma and discrimination are also associated with risk perception and then poor COVID-19 related knowledge and attitude. And our major conclusion is that if this stigma and discrimination prevails, it continues the way we found it, what it means, the implication is that people would not be willing to go for the test in the first place, even if they feel the symptoms, because of the fear that if I go and then it shows that I'm positive, as we indicated in our background, people were ejected from their homes, children suffered victimization in school, so they will want to hide. And when that happens, it means that community level, population level infections would continue to be high. Don't forget that the two types of the infection were the imported ones, and once it's imported, then we start the community level spread. And that is where the difficulty lies in terms of trying to control the spread of COVID. And that is a major conclusion we are drawing, that we need to really look at stigma and discrimination in order to curtail community level spread. Now, what are our recommendations based on this conclusion that we have given? Our findings call for well-planned social education to deal with COVID-19 stigma and discrimination. Now, who are supposed to be doing this? Who should be doing this? Of course, our health and information ministries across the country, and of course, at large, the whole of the African continent. This is what we should be doing. I know countries have done this a lot, especially at the time that the pandemic came. We had a lot of funding, and so there was so much happening. But it looks like we have loosened our guard, and that is why there's a resurgence of the prevalence. And so it means that we need to get back to work and then work on this. Of course, the media, you've been our number one partner in this. We plead that the media takes this up again and then intensify the education of communities so that the likelihood of people stigmatizing and discriminating against others would go down. Of course, health-focused NGOs, they are in the communities, and we are talking about community level spread of COVID-19 and the stigma. So they also have a very important role to play, and all others, it's a holistic effort that has to be put in. So anybody, individuals that have to play key roles in helping us bring down the pandemic. We are saying that we should work assiduously to ensure that people's discriminatory and stigmatizing behaviors are reduced. And of course, very key in these are people we call credible sources, reliable sources. Like you have a medical doctor on Joy FM, Mr. Opoku Gakpo, you are here. You call a medical doctor and he's talking and he's dispelling some of these rumors and mislabelings, which result in a lot of the stigma that we have. Then you realize that people would then want to take these people seriously. So medical doctors, health workers in general, traditional leaders, these people on board. And then then the public, it's as researchers who made these findings to help to bring the pandemic. And of course, the major campaign now has been on the vaccination. And so with this stigma, even the stigma, we didn't find this, but then other studies have shown that with this stigma and discrimination, people are not even ready to go for the vaccine. In Ghana, we have door-to-door vaccine delivery. The Ghana Health Service has done so well, they take it up. People wouldn't mind the team. They won't mind the team. And so it's a major challenge, and it boils down to intensifying the education that will let people buy into the campaign that we are trying to put. And of course, this effort should not be only in the English language or language, wherever we find ourselves. And then of course, the local languages that resonate with the people, that they really understand and can say, oh, okay, they said this, so okay, we have to do this. Local language use is very key. And then I'll go back to the media, that those media
Thank you, gentlemen, for your wonderful research and your interest, your ongoing interest in COVID-19. And I do agree with a large part of the policy recommendations, which is really what we do need to move the vaccinations and COVID prevention efforts forward. I do, though, have a bit of concern about whether your initial questions with relation to attitudes and knowledge were related to our attitudes and knowledge towards active COVID disease rather than COVID survival post-disease. And I do wish there were questions that involved COVID survivors themselves, because when I look at the questionnaires, at least what we saw on screen, most of the questions were, if you were a doctor and you had a COVID case, would you, or if you were a nurse? And I do look at it with a bit of concern. I saw the invite to the call on a continental platform, and I do know that we have done well as a country to do our best, to do the most with what we had with COVID. And there is still more work to do, but I do think that we still need to research more into whether actually when someone has had COVID and has fully recovered, whether there's actual discrimination. Yes, definitely discrimination for COVID active cases, because there is little knowledge and understanding about the way it's transmitted, etc. But I would want more detailed questioning with regards to post-COVID attitudes and knowledge. Thank you.
Okay, thank you. Linda, you may lower your hand now. Gideon, do you want to respond to that?
Yes, Dr. Mo has actually joined me. And so we'll respond. I'll respond, and he will also come up with it. So thank you very much, Linda, for your question. And then we can tell there were just about 21 slides. So clearly we were restricted to share all the information that we have. It was a comprehensive study that we conducted. There are many more findings that we are going to be sharing in the future. But to answer her directly, we actually asked questions about people's attitudes towards COVID-19 survivors. And some of the findings, I've noted them here. About 13% said they will not stay in the same house with someone who had recovered from COVID-19. And as many as about 22% said they will not even work with them. And even for those questions that were asked, whether you would work with an employee, if you're an employer, with someone who had recovered from COVID-19, about 21% said, no, I'm going to dismiss this employee and I will not be able to work with that person. So clearly the questions were asked on people's attitudes towards those who had recovered from the disease. And so, I mean, if we share the manuscript eventually with you, you'll see some of these findings there. But definitely we're limited by the number of slides. Okay, Dr. Mo is here.
Yes, Daniel, sorry, I got lost at a point. The internet has not been my very good friend today. But yes, to add to what Gideon said with regards to Linda's feedback, we actually, as he said, it's a whole project that we carried out, and there's also a qualitative part of it. This is just the quantitative bit focusing on adults, and so we have a qualitative section which was purely focused on the survivors themselves. So we interviewed them, and in the future, I'm hoping that when those findings are also made available in terms of publication, we will continue to have this discourse, and then we can lay bare those findings as well. But this one was just a population-based study, just the general population. So that's why we didn't have the specifics in terms of the survivors themselves. Thank you.
Thank you very much for that response. So do we have any other question? Maybe you can lower the stop the presentation now so that we can be able to see everybody and see the hands. Gideon, you can stop the presentation. Okay, so now I can see almost all the names. Anybody with another question based on what you had, what you know, or any other thing in the same area that would like clarification from the two experts? Sharon, do you want to ask a question?
Being that the research was done in 2020, how relevant is the research to the context that we have right now where we have vaccination? Is it still the same case? Are there still high rates of stigma and discrimination in Ghana?
Okay, all right. Thank you very much. So, as a country, yes, our vaccination rates have gone marginally up. But then the challenge is that a lot of people are not accepting the vaccination. In my presentation, I mentioned that we even do door-to-door vaccination with the Ghana Health Service. So they go to the community level, the community health workers, for instance, go to the community level with the vaccines, or they station themselves at vantage points in the community and then invite people. Sometimes they even come to our churches. Last Sunday after church, they announced everybody should go and vaccinate. But we are saying that because of the stigma, so the stigma is internalized, right? So yes, some have been vaccinated, but the lots of people who have not been vaccinated are not willing to do so because of that internalized stigma that is prevalent. So yes, the higher level of vaccination could indicate the reduction in stigma, but it's still less than 20% the last time I checked. So it means that there's still a lot of the stigma prevalent.
Okay. So
Yes, there is, I think, thank you for that. There's also another quick question from Joseph Opoku. Joseph, would you like to put the question?
Yes, Daniel, I have what I have in the chat and maybe two others. Maybe I'll just go through them very quickly and hear responses. So the first one, I'm asking that from the findings of the study, almost half of surveyed adults exhibited stigma and discriminatory tendencies towards COVID-19 survivors. So I'm asking, to what extent can this finding be generalized? We know that usually survey looks at specific individuals and not exactly everybody in the population, but there are more than 30 million Ghanaians. So this finding from the research, to what extent can it be generalized as representative of the general behavior of Ghanaians? And would it be fair to say Ghanaians generally stigmatize COVID-19 patients? That's my first question. My second question, I probably missed this in your presentation, but if you could reiterate it for me, I'll be grateful. What exactly do you describe as stigmatization? We all know that people need to exercise a bit of caution in dealing with people who have been exposed to COVID-19. So for example, when we are in an office space and someone is coughing, would say, go back a little. If someone has been a COVID patient, we would want to probe and ask questions like, how many days have you fully recovered? How many days have you been in isolation? So then my point is, where do we draw the line between stigmatization and being careful, so that then whatever findings that you came up with probably didn't confuse the two? Those would be my two quick questions. I have a third and a fourth, but I think I'll leave it here for now. If there's time for the others, then I'll come back to them.
All right. Okay, I think I'll take the generalization one, and then Gideon, you can take the stigma and when you should be careful and draw the line between what the Ghanaian will say, be careful, and then stigma. Yes, with the generalization bit, we can confidently say that our findings are generalizable to the population. When Gideon was speaking, he mentioned the level of multi-level sampling that we did, where we first of all put the entire country into 3 ecological zones, which gave equal opportunities to all 16 regions to be selected in the first place. And then out of that, we selected 3 regions from each of the clusters. And then out of those 3, we still selected 2 districts from each of the regions. And in the selection of those 2 districts, we still made sure that we had the rural-urban dichotomy. So we can confidently say that our findings are very representative of the Ghanaian population.
Okay. So to add to Dr. Amu's response, may go back to the other question that was asked before Joseph's question, where I told you the period within which we collected the data. This was about 2 years ago when the COVID-19 was at its peak. And at that point, there were many unknowns about COVID-19, and that was what was fueling the stigma and discrimination. But over the period, a lot has been learned, lessons have been learned. And so clearly, you can see all around that people are not actually stigmatizing as they used to do in the past. But to Dr. Joseph Gapo's question about drawing the dichotomy between stigma and being careful. Stigma, as we defined in the background said, it refers to the negative regard or the inferior status or relative powerlessness that society accords to people who possess a certain characteristics. And so for an employer to say that I will not work with an employee who has even recovered from COVID-19, clearly is a negative attitude towards that person. And the ones you refer to being careful clearly are things that even the government in putting measures, those were part of the preventive measures that were put in place for us to prevent infection with COVID-19. So clearly there is a difference. Those are not negative, those are ways of preventing infection. But then where we clearly show very negative, disallowing people who had recovered from the infection from entering into a shop and refusing their children to go to school, with their colleagues, all those are negative things that clearly shows this stigmatization. And we endorse this thing through discrimination, where clearly we take actions against these people and prevent them from living a normal life, though they have recovered from the infection. And so that's, yes.
So to add on to that, I would want to just highlight 1 or 2 of the questions, some of the things that you could do specifically, which takes you beyond be careful. You mean stigma, or you are now acting on the stigma. I mentioned in my presentation that stigma is the stereotype that you have towards the person, and acting on that stereotype then becomes the discrimination. So for instance, something like, I will stay in the same house with a COVID-19 survivor, and the person says, disagree. Obviously, that is not be careful. The fact that you are staying in the same house with a person doesn't necessarily mean you would get the COVID or not. So you say that once the person has it, no way, they will not get close to my house, like a landlord ejecting a tenant. That is purely stigma and not be careful.
Be careful.
The other one will be, I will be willing to sit in the same vehicle with a COVID-19 survivor. This is a clear stigma, that this is clear stereotype. So it is not about being be careful. Yes, you can sit in the same vehicle with a person, but that's why we have the nose masks. You put it on, and then you reduce the risk of getting infected. But don't forget, even the survivors by definition are largely people who do not even have COVID again. They don't have COVID, they have been treated and they are okay. So it is purely stereotyping and goes beyond be careful. But for you to be careful, it means you should wear your nose mask, you should do all the preventive protocols, and then we'll all be safe from contracting. Thank you very much.
Okay, thank you again for that. Just related to that question by Joe, you mentioned something very interesting, that the probability of stigmatization increases with the income. I found that to be very interesting. It's like saying the rich, or those who think they are rich, actually are the ones who are discriminating more or and stigmatizing more than those who can be said in quotes to be poor. What are the reasons for that? Did you find out why people who have more money or have more income are more likely to discriminate?
Sorry, Daniel, I think we lost you at the point. So if you don't mind taking the question again, please.
Yes, I can repeat. You said something I found to be interesting, that there's the probability of stigmatizing. Can you hear me now?
Yes, we can hear you clearly.
Yeah, the probability of stigmatizing or discriminating increases with the increase in income.
Okay.
Found that to be interesting. What did you find out why people who feel that they have more money or are actually more likely to discriminate? What are their reasons?
Yes, so you think that. So you think that.
All right. Okay. So, Daniel, to answer your question, first of all, we need to talk about the fact that this was a cross-sectional studies, and therefore we cannot completely measure the causal relationships that we found. But then we can attribute this to maybe the initial myths about the disease when we were at the peak of the pandemic, where we thought it was more found amongst the rich people or amongst the white people. There was this myth that it was only the rich or the white who were going to get infected. So we feel that there may be some relationship on it as to why the richer people felt that they were more likely to stigmatize compared to those who had poorer income.
It would be interesting to find out more why that is so. And also related in terms of gender, you mentioned there were more men interviewed than women. But from your findings, what did you see comparatively? Who is more likely among the two genders or between the two genders to discriminate more or stigmatize more?
Okay, thank you for the question. Just a look at that, because sex was not significant, and so we did not pull it into our discussion. Let me look at it again, and then we can have the discussion on it. Just a minute. Yes, so sex, yes, as I mentioned, it wasn't significant, a p-value of 0.23, which means that there is no statistically significant relationship between your sex and stigmatizing somebody. But then, of course, the regression analysis, the odds ratio show that females were 10% more likely to stigmatize and discriminate against those who are survivors of the disease. And so that was our finding. But it wasn't, we cannot associate the two. There was no significant relationship. But of course, as it happened, we could then adduce reasons for its occurrence. And then, of course, when you listen to some of the questions that I read out to constitute the stigma scale, it's about the be careful thing and women being more cautious, looking for more space and not wanting problem for themselves, for want of a better word. I believe that could be a reason why a female would have a higher likelihood of stigmatizing somebody who is a survivor. But of course, as I mentioned, we did not find any significant relationship, so we cannot conclude that this is a good relationship. Thank you.
Okay, I thank you very much again for that. I saw a hand from Linda again. Linda, you had a question. Do you want to put it across? Or has Linda left the meeting? But she wrote something on the chat like vaccine hesitancy has more to do with education. on COVID than stigmatization. Maybe if you get it, but I don't get it quite well. That's what she wrote. If you
yes,
can
we get what. Yes, we get what she's trying to say.
Yes.
I argued that in terms of vaccination, people are hesitant to get vaccinated, and we could also link this to the stigma. And then she is arguing that the relationship is more
We are losing you again.
With education. To the initial argument I made is that we are not looking at bivariable relationship. We are looking at the fact that stigma affects knowledge. And the knowledge, the willingness to get vaccinated. Right. We just got a project to be running for the next 2 years, and it's purely on vaccine acceptance. And you realize that stigma plays a key role because see, if somebody has that negative tendency, all right, they are not even willing to listen to the education that you are giving. It is a serious confounding variable that clouds the judgment. So it is a myth. There's that relationship between the two. Thank you.
Okay, any other question from media colleagues?
I think we have Dennis has a question. Dennis, go for it.
Yeah, thank you very much. So I would want to know that those that stigmatize or those are being stigmatized, did you actually do any finding on their location? Perhaps maybe when you move from the urban to the rural areas, there's more of stigmatization, or there's more in an urban setting. I mean, did you do any findings on that? And when it comes to you relating the stigmatization with income, did you also delve in deeper to actually find out if it also has any correlation with the kind of work they do, whether they work in the finance sector or agriculture sector or in any other sector? Did you actually delve in deeper to find out if there's any correlation with the different fields of work? Thank you.
All right, thank you very much. The
first part.
The variables you mentioned are all in our analysis, right? For instance, when you look at the region of location, we have a variable there which tells you which region had participants being more likely to stigmatize people who are COVID-19 survivors. When you come to location, we have a variable on that, rural and urban. And then you realize that those who are in urban areas do not really have any higher probability because it's 1-1 for them. So we have all of these variables, but then we did not add them to our presentation because they were not significant. But the argument we made in statistical analysis, others will argue against that anyway because there are various schools of thought now arguing that. But then we were on the assumption, that was what informed our analysis, that once the significance level is not below 0.05 in the minimum, because there are 3 levels, 0.05, 0.01, and 0.001. If it is not at least significant to the P less than 0.05, we're not including it in our discussion because we cannot argue that it had a very statistically significant relationship with the outcome variable, which in this case is stigma. But of course, all those variables are there, and then that direction has been reported, for instance. Yes, Gideon, you want to add something?
Yes, I was saying, in the very first level of analysis, there were some findings that we had, where, let's say, respondents who were in Upper West region or the Bono region were less likely to stigmatize or discriminate against COVID-19 survivors compared to the Ashanti region.
Yeah.
Yes, compared to the Ashanti region. And we attributed the reason to maybe the intensity of transmission in Ashanti region, which was the second highest in the country at the time. And so people knew friends and neighbors who had died from the condition or had been infected by the condition. And therefore, they were more likely to stigmatize so that they don't get infected and so on and so forth. But as Dr. Amu rightly said, these relationships were not statistically significant, and therefore we cannot stick our necks out to be able to defend that your location will then determine whether you were more likely to stigmatize or discriminate.
And the occupation one too.
Yeah,
occupation one too. Yes. So regards to occupation, we also made findings on that. When you look at our table 5 in the main publication that came out, we had occupation groups as unemployed, government worker, working for somebody, and the self-employed. None of the attributes we just mentioned. The attribute is like the options under the variable. The variable is occupation, and then unemployed is an attribute. Government worker is an attribute. So that's what I'm trying to explain. We realized that none of these attributes was significant at all. In a typical regression analysis, even if it's just one of these attributes that is significant, you can conclude that the whole variable is significant, but none of it. And that's why we excluded it from our analysis entirely. But having said, there have been instances where researchers argue that there are some variables that are so useful to you that you don't have to argue for the significant before you can talk about them. But we were working with the significant assumption. And so that's what informed our analysis. But for those who would argue that even if it is not significant, you should go ahead and discuss it, we would then say that in that regard, then the reference category was unemployed. But then you realize that government worker working for somebody, self-employed, were all less likely to stigmatize COVID-19 survivors than those who were unemployed. That means that if you are unemployed, your probability of stigmatizing somebody who is a survivor was highest. Thank you very much.
Thank you very much, Dr. Amu. Thank you so much, Gideon, and the team. I know you said there are quite a number of you. From what I see in the paper, you're almost 9.
Now 11.
You are 11. Yeah, that's really great collaboration. We're really looking forward to such, because very few quality research papers actually come from African universities. And when we see this, we are really very happy. And we really encourage that you do more, and please share with us or through PLOS that we are connected to, Nature and the others. They always share with us information, especially research that is related to Africa, that we can also share and have meetings like this. If you are your colleagues who have done similar things, you can get them in touch with us. We work very closely with Joseph, who is a very good friend of mine for a very long time, and has really helped us to coordinate this. Joseph, thank you, and your colleagues from the entire media fraternity in Ghana, and the rest of us from Kenya, Uganda, and the other parts of Africa that have joined. We look forward to hosting you again, maybe in the next few days or the week after. So thank you once again. Hubert, if you can share the actual paper.
I've shared the paper. I've shared it in the comments.
You've already shared it. Oh, I can see it's already there. The paper is already on the chat. Maybe, Tony, you will download it and share with all the participants that are here, so that they can use it to write their stories for those who are actually going to write a story for. And we would encourage you to do so. So thank you very much, Anthony, and my colleagues here at Science Africa for helping to put this together. And of course, again, Joseph, we look forward to working again on the next press briefing. So from us, bye-bye for now. Thank you once again, Dr.
Something to commend you for the work you're doing. we want to really commend what Africa Science Media Center is doing. Only yesterday in Ghana, there was a misreport of an Ebola outbreak in Ghana, which was actually not true because it was just a simulation exercise that was being done. And a reporter wrongly reported that there was an outbreak of Ebola, the very first in the country. And you can imagine the frenzy and all the anxiety that it caused in the country. And so the work that you are doing to improve coverage and credibility of reporting of science issues is a really commendable thing you're doing. I want to thank you. We've looked at the background of other scientists who have been here, and we feel very privileged to be here as well. And we look forward to coming back very soon with more findings from our studies. So thank you so much for your work you're doing. All the best to you.